Today we're going to speak about urinary tract infections. Obviously, it's a difficult task to cover the entire process or all the different types of UTIs within a 30-minute session. But hopefully I can give you a good overview and you'll cover a lot of points that you can remember. So we're going to go through the different types of UTIs. Now, in order to understand urinary tract infections, we have to understand that it's not a blanket term, and that's something you'll see quite often in primary care and secondary care. People will use this term UTI to essentially describe any type of urinary tract infection. But it's a lot more complex than that. And we have to have at least a basic understanding of anatomy in order to understand the different types of UTIs. So on that picture on your right, you can see that there's, of course, we must have a basic understanding of the urinary tract, but you've got the kidneys. The kidneys then filter urine down these tube-like structures called ureters. And then this gets filtered into the bladder. It remains in the bladder until it gets released down the urethra. So if you have inflammation of the kidneys, we use the term pyelonephritis, which of course means a kidney infection. If you've got inflammation of the ureter, these tube-like structures, this is called ureteritis. If you've got inflammation of the bladder, it's called cystitis. If you've got inflammation of the prostate gland, for males, it's called prostatitis. And if you've got inflammation of the urethra, it's called urethritis. Now, we couple this to have an understanding of whether it's upper tract infection or a lower tract infection. If it involves the kidneys and the ureters, we call it an upper tract infection. If it involves the bladder and the urethra, we call it a lower urinary tract infection. And that's what people mean when they say upper and lower UTI. The symptoms of upper and lower UTIs are distinctly different, and they can be used to initially have an idea of where the inflammation and infection is occurring. So let's start with cystitis. Cystitis is the most common form of a UTI. And if you break down the word, cyst refers to the bladder, and itis is a term we use for inflammation. So it means inflammation of the bladder. The most common cause of cystitis is a bacterial infection. It can be caused by a fungal infection or foreign bodies. A foreign body could be if you have a kidney stone, for example. This can lead to cystitis, as well as trauma. It's most commonly caused by an ascending infection. And what we mean by ascending infection, it's the ground up. So it's caused by bacteria that make their way up the urethra, into the bladder, and then adhere to the bladder's mucosa, that lining of the bladder. So urine is normally sterile due to its high urea content and low pH. This environment creates an environment that's not favorable for bacteria, and that's part of its protective mechanism. However, some bacteria are very smart in the way in which they can adjust the pH of that environment. One bacteria in particular that does this is Staphylococcus saprophyticus, and we'll speak about this later. And what it can do is it can use urease, the enzyme urease, to essentially change the environment, the pH of that environment, making it more favorable for bacteria. The other thing that prevents infections from occurring is that unidirectional flow of urine. We need urine to flow in one direction in order to prevent bacteria from adhering to the urethra, making their way up into the bladder and attaching to the surface of the bladder. So that unidirectional flow prevents UTIs. So if bacteria can work against these mechanisms and can adhere to the bladder's mucosa, they can cause an infection. So of course, we've got two families of bacteria. We've got the gram-negative organisms, and one thing to remember in particular is E. coli. E. coli is a gram-negative organism that's responsible for about 80% of lower UTIs. And then the next bacteria to remember is Staphylococcus saprophyticus, right at the end. That's a gram-positive bacteria. It's a it's quite unique in the way it can make its way to the urinary tract. The way we consume it is it can live on contaminated meat. We consume the meat. It doesn't colonize any part of our body, makes its way and becomes part of the normal vaginal flora. And that way it can make its way to the urethra and cause a UTI. A very unique way in which it causes an infection. Other organisms are Klebsiella, Proteus, in particular Proteus mirabilis. And I want you to remember this organism as well, because some options that we use to treat a UTI will not cover Proteus. And this can be an indication that Proteus is causing the infection, as well as Enterobacter, Citrobacter, and Enterococcus. So let's talk about the risk factors of a UTI. The first risk factor is sexual intercourse, and this is because it allows the introduction of organisms into the urethra and they can make their way up the bladder. Another factor is if you're a woman, you're more likely to get a UTI than a male. And the reason for this is I spoke about the urethra. The urethra in males are a lot longer, and therefore it's more difficult for bacteria to make their way up the urethra and then attach to that lining of the bladder. And another factor is postmenopausal women. The reason for this is due to their decreased estrogen levels, they have a loss of their normal protective vaginal flora, increasing their risk of developing a UTI. Another factor is catheters. Catheters allow pathogens to introduce themselves directly into the bladder, and they don't have to do that climb up the urethra, as well as diabetes. Now, in our normal immune response, neutrophils move through the blood to the site of the infection, but this process is called diapedesis. This process is inhibited by prolonged periods of hyperglycemia, of your high blood glucose levels. What diabetes also does is it inhibits phagocytosis. So these two processes are inhibited due to prolonged periods of hyperglycemia, and therefore you're more likely to have a urinary tract infection. Another factor is impaired bladder emptying. Impaired bladder emptying means that you've got stasis of the urine. So the urine remains in the bladder. It allows more time for bacteria in the bladder to attach to the lining and cause an infection. Let's talk about the symptoms of cystitis. So you can have suprapubic pain, which is pain in the lower abdomen, dysuria, which is pain or difficulty urinating. Patients will have an increased urination and an increased frequency of urination and an increased urgency of urination. And elderly patients will experience fatigue, incontinence, as well as delirium. This is very important because it's very difficult to differentiate between delirium that may be caused due to sepsis or delirium caused by cystitis. So tests for cystitis, the first test you can do is urinalysis, and this looks at the presence of white blood cells in the urine. And when people look at a test tube of urine for a patient with a UTI, you'll notice that the appearance is cloudy. The reason why it's cloudy is due to that white blood cell content. So white blood cells can be found in the urine, but if there's an abnormally high amount, and this is more than 10 white blood cells per milliliter, we will consider the possibility of a UTI. Another test we use, which has come under the spotlight, is a dipstick test. The reason why it's in the spotlight recently is NICE recommends that it shouldn't be used as a diagnostic test for elderly patients and those with a catheter. The reason for that is these two groups of patients already have a high levels of leukocyte esterases as well as nitrites, which is what you're looking for with a dipstick test. So in terms of leukocyte esterases, it's an enzyme produced by leukocytes, and therefore high levels of this indicate a high presence of leukocytes within the urine. Nitrites are another another thing that you're looking out for. And the reason for this is gram-negative organisms convert nitrates into nitrites. And therefore, a high level of nitrites in your blood indicates that you've got a high presence of gram-negative organisms. That one thing to note is I said gram-negative, and I also said to you that gram-positive organisms can cause a UTI. So if you've got Staphylococcus saprophyticus, a gram-positive organism causing this infection, you won't have high levels of nitrites. So it shouldn't be used as a diagnostic tool in itself. And then we've got urine cultures. Urine cultures are the gold standard. It's where we take a midstream urine sample from a clean catch, and if we find more than 100,000 colony-forming units per milliliter, we will say that this is a positive sample. A clean catch means that you've taken the midstream urine, so that initial production of urine will catch bacteria at the end of the penis or the vagina, and that would contaminate the catch. So you want to get a midstream sample that's taken in a way that prevents you from getting any organisms from the end of your genitals. So that midstream urine catch is the gold standard for testing. One thing that you could find is sometimes you will find a positive urine analysis. So you find loads of white blood cells in the urine, but you'll find nothing in the urine culture. This indicates urethritis. Urethritis could be caused by Neisseria gonorrhea or chlamydia species, and that's when you're thinking of a sexually transmitted infection. A positive culture should always be taken into account with clinical symptoms. If a patient doesn't have clinical symptoms, you don't want to be treating. You may not want to be treat if it's an uncomplicated case. If it's a case of a pregnant patient, for example, then you may consider treating because of their high risk. So treatment and prevention. In a general view, treatment is with antibiotics and pain relief for the dysuria. In terms of self-care, you have to ensure the patient has adequate hydration to prevent stasis of urine, empty their bladder as soon as possible, have good hygiene, and this prevents fecal organisms from making their way up to the urethra. One thing to note is E. coli is found in the feces. So the fact that it is the most common organism indicates poor hygiene, and there's no evidence of using these cranberry-based products. It's one thing that we used to say historically, but now you'll find it on the NHS Choices website that we no longer recommend cranberry-based products. Now let's talk about acute pyelonephritis. Pyelo refers to the pelvis. In this case, you're talking about the renal pelvis. Neph refers to the kidney, and itis refers to inflammation. It's a type of upper UTI. It's defined as an inflamed kidney that develops quickly, hence the term acute, and it's normally caused by a bacterial infection. Again, just like a lower UTI, it's commonly caused by ascending infection. Very rarely, it can be caused by a descending infection. And this means organisms made their way from the blood into the kidneys. And this could be either E. coli or Staphylococcus aureus. But in these cases, you'd have a patient that has these organisms in their blood. It's a very rare circumstance. Risk factors are the same. Sexual intercourse, increased risk if you're a woman, postmenopausal, catheter-associated UTIs, diabetes, and impaired bladder emptying. I won't go through this again. Now, this is another rare circumstance that's very important. Between the ureters and the bladder, consider this a one-way flap that only allows urine to go from the ureters into the bladder and prevents backflow. If you have a malfunction of this flap, you can have a condition called vesicoureteral reflux, VUR. VUR is more common in infants and young children, and it's a very severe case, and it's due to the failure of this vesicoureteral orifice, this essentially a flap. It could be caused by a primary congenital defect, or it could be caused by bladder outlet obstruction. Now, the reason why this is important is if you have bladder outlet obstruction, you increase the pressure in the bladder and you can distort that valve, allowing urine to flow back into the ureters and into the kidney. And if you look at this diagram, you can see on the right how inflamed the ureters and the kidney can become because of this condition. Causative organisms of acute pyelonephritis, again, E. coli, Proteus, and Enterobacter. They can also be caused by organisms from the bloodstream, such as Staphylococcus aureus and E. coli. Again, this is very rare, it's less common. Now, symptoms of upper UTIs are different and can distinguish between a lower and upper UTI. These include nausea, vomiting, fever, rigors, and flank pain. So pain in the lower abdomen and the sides. If a patient's complaining of pain in the lower abdomen and the sides and they're experiencing a fever, this could be indicative of an upper UTI. And it's often used to distinguish between the two. In terms of prostatitis and ureteritis, you'll see these very similar sorts of symptoms. These symptoms will be more commonly seen with ureteritis and prostatitis. Due to the fact that it's not very common, we won't cover it because we're intending for this session to be an overview. So when do we take culture and sensitivity testing? In the United Kingdom in particular, we treat a lot of these infections empirically, meaning we treat it without actually taking a test. And the reason for this is the high quantity of UTIs that you would see. Ideally, you want to be taking these tests, but most commonly we treat it on symptoms or a dipstick test. But when do we take midstream urine cultures? If a patient's experiencing recurrent or complicated infections, and recurrent here means 3 or more times within 12 months, if a patient has suspected pyelonephritis, and we went through these symptoms, if the patient is a male, the reason for a male is because of that long urethra, you wouldn't be expecting males to be having a UTI. And because of this, you want to be looking at the fact of whether or not there's an anatomical abnormality. Catheterized patients, these patients will have frequent UTIs and they'll have UTIs with more complex organisms. One thing that I'll see often in hospital is patients with catheters having Pseudomonas aeruginosa infections. Not very common to see in community, but you will see in hospitalized patients that have repeated infections, as well as treatment failure or persistent symptoms. If a patient's had a course of antibiotics and it's not proved to be effective, you want to be finding out why. Elderly patients with 2 signs of an infection. So let's briefly talk about treatment of UTIs. Symptoms should resolve within a few days of antibiotic treatment. In many cases, they're self-limiting. If they are self-limiting, why are we treating with the antibiotics? The reason for this is the evidence has shown that it's very good in terms of symptomatic management, and it also reduces the frequency, it reduces the duration of that infection. Ensure hydration and pain relief. Hydration to prevent urine from staying in the bladder, and pain relief because patients would experience a lot of pain when urinating. So generally we say if it's symptomatic, you need 3 or more symptoms and you can consider it a low UTI. And this would be taken in combination with a dipstick test if they don't fall into those categories. If they do, then we can consider midstream urine cultures. Asymptomatic UTIs. With asymptomatic UTIs, you don't have to treat all the time unless this patient is pregnant, then you won't be considering the high risk associated with it. There's no evidence to show that bactericidal antibiotics are better than bacteriostatic antibiotics. Bactericidal being the ones that kill these pathogens, and bacteriostatic being the ones that prevent their growth. And for lower UTIs, urine cultures are always better than blood cultures. The reason for this, as I said to you, it's very rare for you to be having a descending infection. It's very rare for organisms to make their way up, all the way up past the kidneys and straight into the blood. So if it's a rare circumstance, blood cultures don't hold much value in this circumstance. And antibiotic sensitivities will vary in different areas. So you have to take that into consideration. So pregnant patients and males, you treat them differently. And one thing you want to do in particular is send a midstream urine for culture and sensitivity testing. Offer immediate antibiotics because of their high risk. So we are sending the culture. Once we receive the results back, then we can treat in accordance with the sensitivities. And for a male, this may indicate an anatomical abnormality because of that long urethra. And NICE advises to state to these patients to seek medical help if their symptoms worsen at any time or do not improve within 48 hours of taking an antibiotic, or they become very unwell. And this is where you would guide people to signs of sepsis, a fever associated with your UTI, and you should be looking for help. So we're going to run through lower UTI treatment in this webinar because of the time constraints. We've got 4 options really. We've got Nitrofurantoin, Trimethoprim, Pivmecillinam, and Fosfomycin. Fosfomycin is one you won't come across very often, and the reason for this is it's normally reserved for these pathogens that produce ESBLs. ESBLs are extended spectrum beta lactamases. These are these enzymes that microorganisms can produce, and they can render a lot of the antibiotics that you use ineffective. So fosfomycin is good in this area, but you want to reserve it for that because you don't want people to develop resistance for it. Always consider local resistant rates. Trimethoprim in some regions in the UK have 40 to 42% resistant rates. So really you don't want to be treating these patients with trimethoprim empirically, meaning without you knowing what the causative organism is. And look at previous culture and sensitivity results, if they are there, and previous antibiotic use. Always consider the renal function, because once we start going through the antibiotics, some cannot be used with poor renal function. And consider current prophylaxis treatment. If they're taking Nitrofurantoin for prophylaxis, we wouldn't use it for treatment. And that's what NICE states in the introduction of infections in the BNF. So Nitrofurantoin, it's not systemically active. It needs to be activated after it's consumed. It's converted by bacterial nitroreductases to the intermediates, and they inhibit DNA synthesis, RNA synthesis, and protein synthesis. Do not use this if the renal function is poor. Avoid it if the eGFR is less than 45 milliliters per minute. And you have these as an immediate release preparation as well as a modified release preparation. For compliance, most commonly you will see them prescribed as modified release preparations because it's twice daily for 3 days. It's not effective against Proteus species. Like I said to you before, Proteus mirabilis is innately resistant to Nitrofurantoin. So if it's caused by this organism, which with the statistics I gave you, it's not very likely. If you've got treatment failure with Nitrofurantoin, you need to be considering the possibility of Proteus and sending for a midstream urine sample. Trimethoprim prevents the synthesis of bacterial DNA and ultimately continued bacterial survival. The manufacturer advises for the dose to be reduced when the eGFR is less than 15 milliliters per minute. And that's very important because this may be an option if Nitrofurantoin cannot be used. And it's no longer used as a first line in many cases due to its increased resistance. So always check local resistant rates. The dose in the BNF is 200 milligrams twice daily for 3 days for uncomplicated cystitis. Then we've got Pivmecillinam. Pivmecillinam is a penicillin-based antibiotic, so you always have to consider penicillin allergies. It interferes with the biosynthesis of a bacterial cell wall. This is very similar to other penicillins that you would see, but the way in which it does this is different. Of course, in practice, wouldn't make much of a difference. Initially, you need to give a higher dose of 400 milligrams, followed by 200 milligrams every 8 hours for a total of 10 tablets. It generally does have lower resistant rates. This could be primarily due to its lack of use. So you could see that increase in the future. The side effect for this is patients may experience a secondary fungal infection. And then we've got fosfomycin. Fosfomycin is a phosphonic acid antibacterial agent, and it's active against a range of gram-positive and gram-negative organisms. The beauty of this, it's only one dose. It's a 3 gram dose. Again, you've got the possibility of a secondary fungal infection, and this is due to the fact that you're covering a lot of organisms, and this allows fungi to thrive. It's taken on an empty stomach, and it's also, the reason why it's taken on an empty stomach is food can reduce its bioavailability, and it's preferably taken before bed after emptying the bladder. The reason for this is the way it has its effect is it accumulates in the bladder. If you want it to accumulate in the bladder, urinating can reduce its effectiveness. So you normally tell the patients to empty their bladder, take it before bed, and the hope is that they don't visit the loo and urinate during the night, and you can allow that dose to work. Self-care, you advise patients to wipe from front to back, and this is to prevent fecal organisms from making their way to the urethra. Try to empty your bladder fully when you go to the toilet to prevent urinary stasis, and drink plenty of fluids, advising patients to increase urinary flow. Taking showers instead of baths, because bath water can allow those organisms to remain in the bath water. So to improve hygiene, you would advise showers, to wear loose cotton underwear, as this can be irritating, and to urinate as soon as possible after sexual intercourse, because you've got the introduction of a lot of different pathogens, and you want to allow that flow of urine to reduce their ability to make their way up the urethra into the bladder. So things that we have to consider: is it a sexually transmitted infection or is it a UTI? If the patient is complaining of pain during intercourse, genital blisters, a sore throat, as well as nausea and fever, which can be acute pyelonephritis, or spotting between periods, these may indicate a sexually transmitted infection. So it's something to keep a note of. So to summarize, we know that there's several types of UTIs. The symptoms of lower UTIs and upper UTIs can be used to diagnose, but not necessarily diagnose. It distinguishes between the two. And then if it's symptoms of upper UTI, you want to be looking at microbiology, culture, and sensitivity testing. E. coli is the leading organism causing UTIs. High resistant rates of Trimethoprim have forced us to stop using that as a first line in many circumstances. And if a patient experiences signs of sepsis associated with a UTI, this could be due to the fact that UTI often leads to sepsis, and we'll use the term urosepsis, and you'll see that very common. It's very common in a secondary care environment. So knowing the signs of sepsis, the best way is looking at the UK tools for the sepsis 6 pathway, which I can highlight or give you the link via Instagram. So this is a general overview of lower UTIs and upper UTIs. Like I said before, in terms of any questions you have in terms of the material, we'll go through that on Instagram stories. I hope you found this useful.